Hi there. Good morning. Welcome to you all. Nice to see so many young faces. Okay, so we've just heard how APL might be able to help the Italian mathematics for schools and all the rest of it. I'm going to try and tell you how APL might make us healthier. And as Tony said earlier on this morning, that's a big sell. Well, it is a big statement to make. Whether I'll succeed today, we'll find out. But I think there's a lot of stuff going on in APL at the moment. We're doing some really great things amongst ourselves and others. And we should be shouting about them. We should be actually standing up and saying, look at what we have done, look what we've achieved. Because some of the achievements are truly fantastic. So today I'm going to talk to you about my product, or my company's product, which is called Cosmos. I wasn't going to do a demo today of the actual product itself because there's an awful lot of data flying backwards and forwards to make it work, and that's not necessarily a good thing here at the moment. So I've just put some screenshots in, and I assumed that most of you had already seen Cosmos in any event. I hadn't appreciated the numbers who would be coming in today who have not seen Cosmos. So, Cosmos. The original concept, Simon and my colleague in America, we were talking about data in general and the sort of things we've been doing and we wanted to do, and for some of the customers that we've been talking to. They all had very similar problems, they all had loads of data, and we wanted to build a tool for them which allowed them to look at their data, making no preconceptions, making no assumptions about what the data meant and what's behind the data. We wanted it to make it understandable. We wanted the interface to be a little bit different. And we wanted to be able to look at as much data as possible, not just one data set, but multiple data sets, if we possibly could. And we started our discussions looking at two products that we'd been playing with, 15 years ago, maybe 10 years ago, something like that, quite a while ago. One was to do with neural networks, connecting nodes together and looking at how different nodes interacted. And the other one was a product at the time called Netmap. Some of you may have seen it, but basically with Netmap, it takes information and puts it all on the periphery of a circle and then draws lines between the points where there's activity between them. And it was at the time it was being used by the police forces to look at telephone conversations between criminals and mapping who's phoning who and what, and the line thickness indicated which calls were happening most often. We thought we could try and meld the two things together somehow. We didn't quite know how at the time. But I went away, and that's my spec. That's my first draft of the Cosmos design. Didn't really know what all of it meant at the time. But that was about 2010, 2011. But the key point was this bit in the middle, really. A mechanism to diagrammatically show the underlying data. And then around it were all sorts of controls to do stuff with it and display it in different ways. Now, as it turned out, our interface is thankfully a little bit nicer than that. But it's not a million miles away from where we started our original thinking. If I just jump forward very quickly to today, the same product, we're using it actively in business. We're looking at so-called big data. More often that's really more complex data in actual fact. But big data and the complexity surrounding it incorporates small data. Some of the data sets we work with are really tiny, small spreadsheets, little, few columns, few rows. Nothing very sophisticated about them at all. The power comes from being able to take all of these data sources and pull them in together and look at them side by side, because then you can see things which you didn't necessarily realize before, things that weren't necessarily obvious. So our current data sets we're looking at from one of the companies in America, it's about 8 terabytes in total. 250 million patient visits and 45 million unique patients. And a patient visit, this is where a patient goes to a hospital typically, They may have 2,000 to 3,000 separate cost items, for example. So if you're doing an analysis of cost over the whole data set across all the hospitals across all of America, the amount of calculations, the amount of node points is truly amazing. To actually analyze it, to get it into your head and try and work out what's an expensive treatment, what's a cheap treatment, again, it's not an easy thing to do. And you certainly can't do it in tools like Excel, for example, because you have just too much data for it to hold. The other thing which is very important, because the data is complicated, we make assumptions about what's going on, what's underlying the data. And the obvious statement is not necessarily as obvious as you might think. So one of the things we've been trying to get over to the researchers and the companies we're working with is to move away from their reliance on preconceived ideas. A typical research will go along the lines of they'll do something in the lab, they might have some paperwork they've done some research online, and they come up with an idea. And they then have to prove the idea is valid. Of course, it may be, it may not be, we don't know at this stage. So to do that, they go away to a data collection agency, for example, their local health service, and they collect data related to their assumptions. And the problem with the approach is the data they get only relates to the assumptions they're talking about. It doesn't cover very much else. So they may be missing a trick from the outset. They may be missing data which actually gives them a better answer than just the assumption they started with. And the result of that is it slows down the process of finding out the real answers. So by way of a simple example, there's a couple of maps here. If we look at the one on the right, this is malignant melanoma, skin cancer, and it's a relative risk. So we've taken out, not me actually, this is Imperial College London did this work. They've taken out the reliance on population density, so it's just the occurrences and the relative risk of getting malignant melanoma, skin cancer in the UK. And you can see fairly clearly it's down in this area here. There are spots elsewhere as well, but fundamentally here. And the first assumption you would say is, well, that's where it's hottest in the UK. That's where there's most sun, and therefore that's where you'd expect to get skin cancer. However, if you look at the map of sunlight in the UK, the reality is the maximum sunlight is over here. It's not there at all. There is an overlap. There is a linkage, clearly, but it's not a clear linkage. So the question shifts from, is skin cancer caused by sunlight, to, are there other factors involved in people getting skin cancer? And if you drill down deeper and you get in additional information, you realize that a lot of skin cancer cases are caused by lifestyle choices. And if we look up here, you can see there's quite a large occurrence of skin cancers here. In fact, the sunlight in the same area is extremely low in comparison. And the likely reason for that is the people up here tend to go on holiday to places like Italy, here, and they don't use sun cream. People in London, they also probably go to holiday here in Italy, but they do use sun cream. That's my assumption. I might be way off line there. But it just goes to show a simple statement can be completely wrong if you don't put it into context. And it also shows the power of looking at two different sets of data side by side. Now this is another example. It's relative risk again for breast cancer in this particular case in the UK. And you'd expect with breast cancer and similar diseases that it would be fairly linear across any continent. There's no underlying cause or no particular driver for the disease itself. And if you look at this map, you can see that that's pretty much the case. Most of the UK is grey, which is the average, and there's a few areas where it's slightly elevated, and a few areas at the top here where it's slightly reduced. However, there was one of the results of this particular exercise, and you can't probably see it from where you're sitting, but there is 2 or 3 hotspots in Wales. There's one up here, there's one here and there's one there, which came to light. And they don't actually know why those hotspots are there yet. But it has highlighted the fact there is a statistical issue, there's a statistical problem of some nature going on there, which is going to cause additional investigation. So the reason I show this particular chart is it's a good example of a top-down view. There's a lot of data behind this. It's a top-down view. And any one of you, if you actually had in front of you, and you could see the colours more clearly, would see almost instantly where these hotspots are, and you could then ask the question, well, why? And in fact, these three hotspots here, they're triggering about 50% to 75% more occurrences of breast cancer than anywhere else in the UK. So if I go back to the start again, my story, where do we start from? We had an expertise in our early days with pharma data, medical data, and forecasting of data. So we targeted the pharma industry, and because Simon, my colleague, was living in America and he had a lot of contacts in America, we settled on the US medical market and areas. So we have data collection agencies, pharma companies, and clinical research agencies. So our first phase, we wanted to build a visualization tool. We wanted to make it look different. We wanted to build something pretty quickly because we didn't have an awful lot of time to get to market. And we initially targeted companies who were selling their own data. And they wanted tools they could pass on to add value to their overall proposition. One of the things we knew from the outset, though, was that whatever we produced, it had to be unique, it had to be sexy, had to be a little bit different, and had to grab the attention. And we were using, well, what we're using now in actual fact rather than then, is an APL Flash and My Server interface. Flash being on the front end, My Server somewhere in the middle, and APL doing all the gritty stuff on the servers in the background, doing all the calculations. So this is my first demo. Those of you who've seen Cosmos will probably get the gist of what we're looking at straight away. And for those of you who haven't seen it before, just in principle what we're looking at very quickly, in the center here is a node which represents the entire data set, all the nodes. And this particular one, I can't remember what it was. I can't read it either, so it's data. It's data. And then surrounding the central yellow node in blue are other related nodes. This is probably, as I said, I can't quite read it, this is probably disease categories. The idea is we can change the line thickness, the line colors, and all those sort of things to indicate significance or frequency or whatever we want to show, and we can go down very many levels. There's no actual formal limit built into the system. We reckon you could probably relatively easily do about 20 dimensions, and then expanding these nodes out one after another if you wanted to. And we have a little tool called Scout, which when it's working fully will do that work for you and find the statistically significant routes through the maze of pathways automatically. So this particular interface got people's attention pretty quickly. They liked it, they understood what they could see. It's a top-down view, so immediately features were coming out of the data which they wanted to investigate further. And I have to stress, the Cosmos doesn't give you answers, but what it does do, like those graphs, the maps, it shows you where something's going on that you might be interested to explore further. It gets you to the point of interest faster. That's the key point. Phase 2, we wanted to add some analytics. The scientists immediately wanted to do number crunching and do clever things. And you won't be able to see this very well, I'm afraid. But here is another diagram. It's the same front end to the one we've just seen. The only difference here is we've applied some stats over the front and done some calculations, and we're now viewing the network of significant features in a slightly different way. So a little while ago we got involved in some clinical trials. It was macular degeneration, which is all to do with the eye and the retina. And the people in question, they saw the tool, they loved it, they wanted to use it, they wanted to make best use to see how they could identify the factors affecting the macular degeneration in their patients. And for that they wanted Cosmos because it gave them this top-down view. And they wanted a dashboard, which is something you've all probably heard of. It's becoming more and more common with many, many applications. And again, I don't think you'll see it very well, but this is basically a very quick screenshot example of two graphs, two progressive graphs. I don't even know you can see, there is a line here, a trend line going through here on this graph, and it's a higher angle on that graph. And as it happens on this particular chart, if you could read it, it's showing that over time there is an improvement to the patient's outcomes using this new treatment, which is yet to come to market. And we are getting this data on a monthly basis. We update the data set, and they use these graphs to see how their clinical trial is moving on. For them, it's becoming very useful. Phase 4, we go back to the drug manufacturers, and we're back to much larger data sets. The diagram we saw just now, the dashboard we saw just now was for clinical trials. Typically, their data sets are quite small in actual fact, in the scheme of things. These are now much larger data sets again. And what we found here was we needed to provide for the customer what we're calling a patient flow. What they're interested in is to see across a population, in this case the US again, how people's treatment varies over time. We're using Flash, APL, my server, and HTML5 now. And in fact, I've put in here rather cheekily APL squared, because the calculations now beginning to happen really do start to tug at APL. We're using it very heavily inside the system, multiple processes going on, parallel processing in due course. What we now see with a patient flow diagram is something like this, very similar to the very first chart you saw. The difference here, though, is we've identified drug sets which the drug companies are interested in. Doesn't matter what they are. And this is I think this is just two or possibly three levels. So the patient starts here in the middle. They have a treatment regime given to them by their doctors or clinicians. They follow that regime for a period of time, and they, for whatever reason, maybe they're allergic to the drug, or maybe it's not working for them, they switch to another drug. And these are all the pathways of all the drug therapies that they can use for different diagnoses, different diseases. And this particular diagram is quite nice to watch it being built up actually by the system, but it does transmit quite a bit of data back to here. Can go to 20 levels, and that's 20 because we've got patients in the center who have had 20 drug treatment swaps throughout their treatment cycle, which may go on for many years. Now, phase 5, this is where we're at sort of today, really, I suppose. And this is now starting to get really quite serious. The amount of data, once again, has gone up a notch, but the requirements have also improved. It's now where APL is now taking a significant role in the whole process of how patients are selected for clinical studies. APL is key to this project now, and we should be starting on it in the next few days in anger. But to try and put some meat on the bones for this, we have this stage here, discovery and preclinical. Basically, it's lab work, and the scientists do their thing in their labs. They come up with an idea, they come up with something which they think might work, and typically that's 3 to 6 years before anything comes out of the lab, and it's going to cost about $1/3 billion to get to that stage. From there we go to phase 1, phase 2, and phase 3 clinical trials. The first phase is of a small number of people, just to see whether or not it's a dangerous therapy or whatever. So it's looking after the safety aspects. Then they move it out to more people, and finally it's potentially thousands of people who go into the trial to see really how this drug is working. And that process can take 6 to 7 years on its own. And is another, let's say, $500 million to come to conclusion. Of course, the drug, whatever it might be, can drop out at any time. So you might spend a lot of money and then find the drug is actually of no use. And then finally, at the extreme right, we've got the Federal Drugs Authority, I think it is, FDA in America. Administration, thank you. They decide whether or not they're going to allow it out into general use. And they have the final stamp of approval. Another $100 million in a couple of years' time. So you can see, in total, one drug is about $1 billion, and it can take up to 15 years from start to finish. What the project we're working on now is to reduce that down. And as the title says, drug development's expensive, it takes a long time. Patients don't necessarily have that time. So the question for the audience, thinking now about this bit, the labs all around the world, not just on cancer, but all sorts of other diseases, are creating stuff. It may be a drug, it might be a therapy, it could be a machine to help the surgeon in the operating theatre. They all go through this discovery in preclinical trial. If we just think about cancer, we just think about America, how many drugs have come out of this and are waiting at this point here? They're waiting to start phase 1. Hands up if you think it's about 200. Okay, we've got 1. Fair enough. How about hands up if you think it's about 400? Okay, we've got about 4, 5, 6 maybe. Hands up if you think it's about 800. Yeah, you've cottoned on, you lot. Well, okay, well done. I think it is actually as well. But it's of that order of magnitude. 800 to 1,000 drugs are waiting here. The problem at the moment we have is we've got 1.5 million new cancer patients presenting each year. You can see the figures there. Only 3% of people with cancer in the US get access to clinical trials. And that's not because they don't necessarily want to go on to the clinical trial. That's because the doctors may not even know the clinical trial exists. Or they don't know whether that person, their patient, is suited to that particular trial. For minority populations, it's worse. It's half that number. I'm not exactly sure in America, although I could probably guess why that's the case. But it's a very small percentage. And quite a lot of the diseases we see and we hear about commonly affect the minority population to a greater percentage. So if we just run those numbers as they stand at the moment, we're looking at, on the basis of 800 drugs, only 30 patients available per drug. And that's assuming that all 30 are suited to the trial. And they probably won't be. So the aim of this project is to get many, many more of that 1.6 million, certainly greater than the 3%. They want to get it up to 20%, 30%, 40%. Give as many patients as possible the opportunity to join a trial so that a drug or a therapy or a treatment, whatever it might be, can be ruled in or ruled out, because not all these drugs work, of course. So when it comes to patient screening, that in itself is complicated. It requires many different data sources. Some of those data sources are not readily available. Some of them haven't even been collected. And there are pages of it. The requirements for a particular patient for one drug can go, the one I saw recently was 17 pages long, just in the descriptions of all the things. And this is the sort of thing you see. I'm not going to bother to read it all out. But it goes into quite long detail about what they're looking for in particular. And every time, each of these stages, you rule out more and more people from your pool of potential patients. And it goes on. So the key is to be able to collect data, collect it, amalgamate it, make sense of it, have the tools available, and APL is not just there's many other tools as well, of course. Be able to use those tools to drill through the data and make sense of it, and see where the important information is being held. So here we are today. We're working on this sequencing project, hopefully next month, and it'll become quite an important thing. It's a very big thing already in America. I mean, the investment that's been made has been truly immense. As you can imagine, they have all these sequencing laboratories being created. They're dedicated to these tumor sequencing, and they want pretty much all of the tumors that get presented to be sequenced. So it's a multi-billion-dollar industry. A lot of it's being done on a non-profit making business basis, and the doctors, clinicians, and researchers can have access to this data basically for free. The drug companies have to pay for it, however. So it's not all for free. And it's an interesting case in point in that a lot of the patients here are actively assisting these companies with their data. They're now actually saying, you can have my data, you can use my data. In much the same way some of us carry organ donor cards saying you can use my organs on my death. These people are actually offering up their information for use in a protected sense, but for use nevertheless, which hasn't happened to the same extent before. So we have Cosmos. It's our tool, proving to be very useful. It's powerful. It's very flexible. It is pretty quick, and certainly it's quick compared to other systems we've seen. And when I say quick, I don't mean we necessarily get an answer in a few seconds. The processing of a vast data set could take an hour, may take 2 hours. But the equivalent using more traditional techniques used to take weeks. And it used to involve a team of programmers who would have to program the extraction scripts into the system, which then had to be tested and validated and double-checked, and the whole process was very slow. At the end of the day, what they produced may or may not have been useful, depending on the assumptions that have been made up front. In our case, we make no assumptions. We say, there's the data, have a look. So it's much, much faster. The whole thing is all about turning around and getting people the drugs they need faster. And the advantage we have, quite literally, is we have APL. We've found throughout the development of Cosmos, we've had to move and adjust what we're doing in line with the researchers, the doctors, the hospitals, the pharma companies. They all want different things. They all want different things in different ways. No two pharma companies want the same thing. And we have to be able to take their data, put it into the system, and then prototype what they need and show it to them actively and quickly. So we need to be turning things over in days, not weeks, months, or even years in some cases. So there we are. In conclusion, we can get the right patients, we can find the data, we can drill through the data and find out hidden meaning in the data itself. And that is all down to APL. I don't think we could have done it in any other language, to be perfectly honest with you. It happens to be our speciality, but then that's the way it is. And I do feel, quite honestly, it can make us healthier.
It's obviously dealing with sensitive data.
Yep.
So what degree has been anonymized, and are there any protections against this data ending up in the hands of insurance companies?
It's a big problem. You may have spotted on one of my slides. I mentioned in passing one of the points was security. The data we get is always anonymized. We're not allowed to have the full data with all the names and addresses and all the rest of it. Some data we have has a unique key, so that if we were to identify something of significance or rather of importance to that patient, then we have the ability to go back to the originating or the source of the data, let them know so they can then deal with it in their own way. But some data we get is completely anomalized. There's no way of going back from where we are. So we're working a little bit blind in that sense. But fundamentally, data security and the protection of patient information is very important.
If you look at the majority of the work you've been doing, the adoption of Cosmos has mostly taken place in the States for various reasons. Presumably data protection issues in the UK is one of the reasons why you have not been able to progress as deep. I would like to know, because you must have now started, as you showed some figures on malignant melanoma and breast cancer, you must now be working with some research organisations in the UK, is that correct?
Yes, we are. Most of the organisations we deal with on a day-to-day basis are big companies. So, people like Pfizer, for example. They're all over the world. So, yes, we are dealing with them in the UK, but only insofar as they've also got offices in America and Europe and Australia and Africa. So, we do, but the protocols around data gathering and data access in America they're still quite strict, but they allow us to do what we need to do. And in particular, the American way of working with this sort of information allows us to take a top-down view where we can collect, without any real preconceived ideas again, a bunch of data, look from the top down and see what it all means. In the UK, the rules are very different, and you're not allowed to do that. They call it data mining, and data mining in this industry in the UK is a bad word. If you're a researcher, a bona fide researcher, you're allowed to see data and get data, but you have to tell them what it is you want. You need to know the answer to your question before you start, almost, which is ridiculous. What you can't do, and I've actually been to the NHS in London, and I've talked to them about it, and they say, yeah, we get it, we love it, it's great, but you can't do it. You can't look down on everything and just see what's there. It's not allowed. Very annoying.
It looks like your application is very specialized to the drug industry, but from my very remote point of view, it looks like it could be used in many, many, many different areas, right?
Yep.
If its main purpose is to look at relationships between nodes in a graph, it sounds like it could benefit to all kind of industries. Do you have plans to expand, or will you stick to drugs?
No, you're absolutely right. The system Cosmos is actually very stupid. It has no knowledge really about data. All it has is ones and zeros inside it, and it just looks for patterns and matches and things which might be of interest. We started on the medical side purely because we had an expertise on medical data, and we had contacts in America with a big network of doctors and clinicians who we could make use of for the purposes of the development. Although some of the stats in the system are a little bit biased towards the medical industry, at the end of the day, an average is an average. The system we have today, we already have got financial pension data in there. We got the ability to bring in some aviation data as well. There isn't any reason why you couldn't have mining data or population data or any other data for that matter. And in fact, we have data in there on the medical side, which is patient clinical data, demographic data, climate data, lifestyle information, and even things, although we're not doing it, but other people are taking things from your supermarket loyalty cards, Club Card, Tesco's in the UK. Even that sort of data is now beginning to be used, very carefully, but it's being used to map people's trends and what they're eating and how that might be affecting their food. So it's an ever-expanding data pool of information.
Paul, can you talk a little bit more about the data source and the architecture of your data, and has this project changed your strategy in managing the size of the data and how you access it?
Well, when we started with good old component files, and they became awkward to use, and they became too slow for many operations. So we're now using memory map files within the system. We have our own architecture and our own way of storing the data. We've got hash tables and all the usual things. But one thing we're finding, and this is again where APL comes into its own, is that as another data set comes along with different requirements, different capacities, we might have to change the way we're working. So we're always looking for another avenue, another way to shave off a few more seconds off the processing, or potentially change the architecture. And one thing we're looking at the moment, or just about to start looking at, is sharding the data. So we have, rather than a single database fundamentally that's in memory, we have it spread out on multiple servers, and the servers doing whatever they need to do to deliver the answers back to us. So the architecture is changing all the time.
Shortening the timeline for clinical research is really exciting.
Yes.
Yes, something that we really need to do. And you've told it from your point of view, in that you are selling a product to various sectors.
Yeah.
Is there any centralized organization that's helping to push this along, or is it all happening from the ground up?
What we're doing at the moment is happening from the ground up, but there are a lot of organisations all over the world, in actual fact, that, you know, the NHS in the UK gets criticised for its tight control of data, but even in the NHS, it's always looking to find new things, and because everybody appreciates these timescales must be reduced, and also the costs brought down. If you can halve your time, you can halve your costs, and at $500 million a pop, that's a big saving. So the various administrations around the world are looking at it. There's all sorts of things going on, a lot of movement, not just in cancer, schizophrenia, diabetes, and other things. So I can't say what's going to happen next because I don't know, but I think at this moment in time there is an awful lot of things going on which will ultimately help us all. Fingers crossed. And I think we're out of time. Thank you.